Eleanor Nwadinobi, President of the Medical Women's International Association, an association globally of female medical practitioners. The Medical Women's International Association is a pioneer partner of the Global Sepsis Alliance. I am deeply honored to be your moderator for this session, which is session 2 for the 2025 and 5th edition of the World Sepsis Congress, under the title Sepsis Epidemiology and Clinical Data. We all know that data is the new gold. We do have sobering statistics that sepsis is responsible for 1 in every 5 deaths worldwide and affecting nearly 50 million people each year. So we have a wonderful lineup of erudite speakers to speak on this very important topic. And to you, our cherished audience, we would like to hear from you, for this is an interactive time together, and we do want it to be as interactive as possible. I do have some housekeeping rules. We would love to hear from you, and please use the Q&A function for your comments. And if you have a specific question, please type the letter Q followed by colon. That way, we'll be able to see your questions clearly and appropriately address them. So let's move right into the sessions. Our very first speaker for today is Mohsen Naghavi, who is a professor of health metrics, sciences, and director of subnational burden of disease estimation at the Institute for Health Metrics and Evaluation at the University of Washington. In his role, Mohsen leads the Institute's work on subnational analysis of disease burden, working closely with international collaborators and country governments, including projects in Brazil, Russia, Iran, China, and Ethiopia. In 2015, Mohsen was named one of the world's most influential scientific minds by Thomson Reuters. This accolade and award was also repeated in 2016. So without further ado, it is my pleasure to ask Professor Mohsen to make his presentation. Over to you, Professor.
Thank you so much. Thank you, Eleanor. I will talk about, because I have 15 minutes, I have to talk very fast. I will talk about global burden of sepsis and AMR. I try to explain how we calculate a little and what is the result and why we calculate sepsis and what is the benefit of the sepsis for the public health and for the improving knowledge. Okay, let's talk about 2021. In 2021, 66 million people died globally, 66.2 million. It was the year that we had COVID. From these 66.21.4 died by sepsis. And as you see that definition of sepsis for us is exactly same as definition that you are using. Acute life-threatening organ dysfunction due to the dysregulation host of response to the infectious. And then based on the method that we published in the Lancet 2017, and we submitted again a new version in the Lancet that will come soon, hopefully. Our method is based on the calculation of the fraction of the sepsis in the multiple causes of deaths, and then apply this fraction after the modeling process to the all-cause mortality and calculate number of the deaths due to the sepsis. But just we do not calculate sepsis. Also, we calculate infectious syndrome. Infectious syndrome is the causes that is bridge between underlying cause and the sepsis. For example, how is it possible that somebody with a or will have UTI? Then we calculate both sepsis and infectious syndrome. Then, based on the number that we have, in 2021, as you see, we have 21 million deaths due to the sepsis, with the 166 million incidents. The reason that is different with our paper, because in the incidence part, we included implicit sepsis. We didn't just calculate based on the explicit, we calculate based on the implicit too. And here in the bottom, you will see by the age, by the time, and you can see that the number of the deaths by sepsis in the children decreased from 1990. In reverse order, number of the deaths with sepsis increased in the old ages and very old ages. That you can see between 50 to 74 number increased, and also in the 75. In other words, number of the sepsis in the children is decreasing, but number of sepsis in the old age is increasing. And here you can see much better that it is comparison between 1990 and 2021. That you can see in 2021, we have big increasing in the age in the 50 plus until 90 plus. And here, distribution of the fraction of the people that die by sepsis. You can see in 1990, we had a big number in the 2019, sorry. In 2019, we had a big number in the poor area, like Sub-Saharan Africa, India. But in the 2021, due to the increasing of the number of the deaths due to the COVID, we have a big increasing in the also developed country. Same as this is age standardized death rate that you can see. Again, we have a big number in all the rich country except of the Scandinavian country, except of the China and Australia, that they had a lower number of the deaths due to the COVID. And also, this is number of the sepsis incidents that, as I said, it is 166 million. Not only we calculate the sepsis, this is infectious syndrome that is bridge between underlying cause and sepsis that you can see in 1990. We had a big number for the lower respiratory. In 2019, decreased after that in the bloodstream. In other words, sepsis number is decreasing, but this decreasing is not is heterogeneous by the different age group. In the under 5 and under 15 is decreasing, but in the over 15 or over 50 is increasing. And this is the pattern in the under 5. You can see that distribution of the infectious syndrome in the children that die with the sepsis is completely different. In neonatal, they die with the bloodstream. In the other age, they die with the other causes like diarrhea or lower respiratory. How we calculated? Okay, this one shows that number of the deaths by the infectious disease as an underlying cause. But the people that die with the sepsis, all of them are not the people that die with the infectious disease as an underlying cause. There are around 5 million, 6 million people every year that they die with the underlying cause as a non-communicable disease, but with the sepsis, as an injury, but with the sepsis. As you see here, in 2023, that we didn't have COVID or COVID was very small, 5.2 million people die with the sepsis in the situation that they had underlying cause was non-communicable disease. But in the pathway of the deaths, they got infectious syndrome, and this infectious syndrome moved these people to the deaths. And this shows that, for example, here is disease that is underlying cause, for example, lower respiratory infections, that is underlying cause, and intermediate. In fact, number of the intermediate, we have 3.5 million deaths by lower respiratory aggregated with the underlying and intermediate, that just 2 million was underlying cause. 1.5 million was people that had other non-communicable disease and they got lower respiratory and they died. And this is the pattern that you are seeing. For example, stroke here, you can see stroke, some of stroke people get BSI, bloodstream infections, some of them get lower respiratory, some of them get skin infections, and some of them get UTI, and they die. And when we calculated sepsis and infectious syndrome, we will try to calculate pathogen distribution. And here is method that we calculate pathogen distribution, and we showed that from 21 million cases, 7 million are sepsis due to the bacteria or bacterial sepsis. And this is the pattern of the pathogen. 33 bacteria can produce sepsis, and as you see, other pathogen like virus, like fungi, make same process, same as bacteria. This is global. We calculate based on this for every country. And you can see we have sepsis, we have infectious syndrome, we have pathogen. One thing that it is important, you can see underlying cause for the dying people with the sepsis during the time change a lot. For example, in the 1990, neonatal encephalopathy was the second. It go to the fourth in the 2019. Or look to the prematurity. Prematurity it was in the fourth, now go to the 10, and then in the reverse order, you can see lung cancer is going up, colorectal cancer is going up, diabetes is going up, all the different diseases. And here it showed that number of the underlying cause with the sepsis is increasing for the non-communicable disease. and for the communicable disease is decreasing, that you can see. Finally, sepsis is preventable. For us that working in public health, we believe that sepsis is preventable with the early intervention. Sepsis is treatable with the good medical care. It's not necessary that 21 million die with the sepsis. It's preventable and treatable. Children are more at risk for the getting sepsis. Then we have to be very careful. Sepsis is increasing in the middle age and old age. There is a big pandemic with the increasing age structure of the community going to the older age. We will have a pandemic of the sepsis. It is on the way. Thank you so much. I think that I finish on the time. Thank you.
Thank you so very much, Professor Mohsen, for your very informative presentation. Indeed, sepsis is preventable with early intervention and timely medical care. And you have given a warning that a sepsis pandemic could be on the way. I will please remind our cherished audience that you can put your questions in the Q&A function. We do have one question for you so far, Professor Mohsen, and that comes from Dr. Ayub Abdul Kadir Abdi from Somalia, who says, does sepsis calculation, can sepsis calculation be done in the private setting, and what method can be used?
Oh, we published our method in the Lancet. You need multiple causes of deaths. You have to have underlying cause and intermediate cause. If you have this data, it is very easy to calculate sepsis. I don't think that in Somalia you can have multiple causes of death, but in some hospital that if you have good death certificate and good electronic data, yes, it is completely possible to calculate number of sepsis.
Thank you so much. We greatly appreciate your addressing that question, Professor.
Thank you.
I will now take us to our next speaker. Our next speaker is Shevin Jacob. Shevin is an infectious diseases physician and reader in sepsis research at the Liverpool School of Tropical Medicine. Over the past 20 years, Shevin has been conducting research aimed at improving the management and outcomes of patients hospitalized with life-threatening infections, especially in resource-constrained settings, with a primary focus on adult sepsis in Uganda. Shevin also has over a decade of experience as a consultant to the World Health Organization on a wide range of sepsis-related topics, including case management of viral hemorrhagic fevers. So I will invite Shevin Jacob to make his presentation. Over to you, Shevin.
Thank you very much to the World Sepsis Congress organizers and colleagues around the world attending the Congress. I am very excited to be able to present on some of our work on the baseline African sepsis incidence study, or BASIS. I have no conflicts of interest to declare. And just to start, as has been discussed with other colleagues in this session, sepsis is responsible for 1 in 5 deaths globally, and about 85% of them occur in low and middle income countries. And understanding sepsis epidemiology in low and middle income countries has been constrained by sparse data at national and regional levels. In sub-Saharan Africa in particular, data availability constraints include limitations in diagnostic testing, disease severity classification, and cause of death registration. And in fact, models estimating sepsis burden in low and middle income countries have had to employ extrapolation from other higher resource settings when data are not available. So for example, data from Mexico had been used to estimate the burden of sepsis in Africa for the global burden of disease. And so these issues reflect important knowledge gaps in our understanding of factors that contribute to the regional variations in sepsis epidemiology. And it was in this context that we undertook the Baseline African Sepsis Incidence Study, or BASIS. And BASIS was a collaboration between the African Research Collaboration on Sepsis, or ARCS, and the African Sepsis Alliance, or the ASA. And it was a study, a multi-country, short-period observational study of sepsis-related admissions in hospitals across sub-Saharan Africa. And in BASIS, we aimed to estimate the epidemiology of sepsis among non-pregnant adults utilizing prevalence and catchment area data, to identify correlates of mortality centered at 14 days, and to describe availability of resources in hospitals providing care to patients with sepsis in the study. So in terms of selecting health facilities, we initially sought interest from members of the African Sepsis Alliance. And we selected partners and sites based on predetermined criteria, which included whether or not they had research experience, what kind of administrative capacity was available at the collaborating institution to help with the research, and whether it was indeed feasible to conduct the study within a budget of £3,000. And then once selected, co-investigators identified hospitals that accepted admissions of adult patients directly from the community. And ultimately, the final network comprised co-investigators from 26 health facilities across 10 countries. And they represented the 4 Africa Union regions. And so we had Ethiopia and Uganda for the eastern region, Burkina Faso, Ghana, Nigeria, and Sierra Leone for the western region, Cameroon, the Democratic Republic of the Congo, Gabon for the central region, and Malawi for the southern region. At the participant level, we included participants who were 18 years and over, if they had a suspected infection, which we defined by at least one of the following in the preceding week. So they had to have either history of fever, Rikers or night sweats, and or empiric antimicrobial treatment. And then as a proxy for illness severity, we, if the non-study clinical team decided that the patient required hospital admission, that was also an inclusion criterion. We did not include patients who were currently pregnant or within 3 months postpartum, nor patients who were had post-surgical infection, nor patients with non-severe, localized, uncomplicated infection. In terms of recruitment, we recruited participants at all the study health facilities in 2 short period phases. During each of these phases, participants were enrolled for 24 hours per day over 7 consecutive days. And then we followed them up to a maximum of 14 days until a hospital discharge, death, or transfer to another health facility. And then at the time of follow-up, we collected information about the participants' vital status, whether there had been rehospitalization in the 14-day period, and whether there had been a need for advanced care, like mechanical respiratory support or renal replacement therapy. At baseline, we collected information about patient demographics, about the patient's pre-hospital course, about any comorbidities, including communicable and non-communicable diseases. We looked at presenting symptoms, treatments received prior to hospital presentation, and then baseline physiologic variables and examination findings. And then at the health facility level, we collected information about the context, and this included the number of hospital and ICU beds, admission numbers, and capabilities for specific investigations and for treatment delivery, including oxygen and vasopressin. So moving to results, we screened about 3,000 patients and enrolled 1,290 participants in these two phases. And in phase one, all 10 countries participated, where we had about 635 participants enrolled during that period. And in phase two, only 8 of the 10 countries participated, but about the same number of participants were enrolled during that period as well. Here we have a table that summarizes some of the participant characteristics. And to highlight just a few of these, you can see that the median age was about 38 for participants. Just under 50% were female, and just about 25% of participants were HIV infected, patients living with HIV, but also important to know that about 37% of patients did not know their HIV status. In terms of clinical characteristics, while there was some variability across sites, there was also some common presentations for participants across all the different countries. And these included non-specific symptoms in about 80% of the participants, and those included myalgia, anorexia, and concentration difficulties. As well, neurologic symptoms were common in about just under 65% of the participants, and just under 60% of the participants had respiratory symptoms, which included cough, dyspnea, or pleuritic chest pain. And as you can see from the panel on the right, the variation in vital signs, whether it was systolic and diastolic blood pressure at the top, heart rate and temperature in the middle panel, and respiratory and oxygen saturation in the bottom panel, the variation across all the different countries was minimal. So in terms of our incidence estimates, our crude estimate was about 241 incident cases of sepsis per 100,000 population. And when disaggregated by sex, this cumulative incidence in men versus non-pregnant women was similar. And then we developed a random effects model, and that adjusted estimate yielded 126 incident cases of sepsis per 100,000 overall. A little bit about pre-hospital pathways. We defined prolonged delay as delay to hospital that was greater than or equal to 7 days. And we found that that was associated with a higher 14-day mortality compared to participants without prolonged delay. So about 14% in those with prolonged delay versus 10% in those without. And in a multivariable logistic regression model, we identified independent, statistically significant variables associated with prolonged delays. And those included participants who reported self-treatment or care seeking at a different health facility before arriving at the study health facility. Those participants who had transport modes that included minibus or public transportation or bicycle, and those with comorbidities like HIV and TB. Also of note are participants who sought care from non-health facility settings, so whether that was through patients or family members or friends, or traditional healers. And in a subset of participants who had access to motorcycle and ambulance, these factors in blue were associated with earlier presentation. Moving on to outcomes and correlates of 14-day mortality, we managed to capture follow-up data on about 94% of the participants at the 14-day time point. And mortality at 14 days was observed in almost 12% of all of the participants. But it is important to note that there was a wide range of mortality across all of the countries, with the lowest in Ghana, which was about 3%, and the highest in Ethiopia, which is about 33.3%. And here we also conducted a multivariable logistic regression analysis, and our crude and adjusted odds ratio showed that there was independent factors associated with the 14-day mortality, and those included age, male sex, prolonged delay, hypotension, and tachypnea. Moving on to health facility characteristics, I'd like to highlight just 4 characteristics on the contextual data that we collected. First, in terms of median annual admissions per facility, there were about 11,000 admissions across the different health facilities overall, and about 20% of these were medical admissions, and just under 3% of these were ICU admissions. In terms of bed capacity, on average, the health facilities had about 100 medical beds, and then 9 additional beds for high dependency or critical care. And health facilities reported about 7 beds per ICU when they did have designated ICUs. In terms of some of the treatments, particularly oxygen, oxygen was supplied in various ways on the medical wards that included cylinders and oxygen in about 40% of the wards, and oxygen concentrators and availability in a much smaller percentage, about 15% of the health facilities. But when it came to critical care areas, piped oxygen was supplied in a greater percentage, about 80% of the health facilities. And then another kind of treatment, specifically vasopressors, we found that nearly all the hospitals had access to 1 or greater vasopressor, with epinephrine being the most common, but notably norepinephrine, which is the first line recommended vasopressor for sepsis, was only available in just over 50% of the health facilities. And as well, only about 30% of the health facilities had access to all 3 of these agents. So in summary, the studies for estimating the burden of sepsis in sub-Saharan Africa are feasible, and we managed to collect quite a good amount of interesting information across all these 26 health facilities with just 3,000. But more comprehensive approaches are necessary so that we can understand the role of country-specific differences on outcomes. And this particularly with respect to the role of underlying comorbidities, etiology and resistance profiles, health-seeking behavior, and health facility capacity. In addition, an in-depth exploration of the delays to hospital presentations for patients with sepsis in sub-Saharan Africa is needed. And as part of that, we really need to start looking into potential interventions for addressing these delays. And then finally, networks like the African Research Collaboration on Sepsis and the African Sepsis Alliance have the potential for additional multi-country studies and trials of sepsis. And in fact, ARCS has now expanded into another consortium called the Sub-Saharan African Consortium for the Advancement of Innovative Research and Care in Sepsis. And if you're interested in learning more about the work underway for STARES, please feel free to click on the QR code at the bottom of the screen to get more information. Just a quick disclaimer for our funders, which included the UK National Institute for Health and Care Research for ARCS and the German Federal Ministry of Education and Research for STARES. And just to highlight that the views expressed in my talk are just mine alone and not necessarily those of the funders. And finally, I would like to give massive thanks to the investigator team across all the 26 sites in sub-Saharan Africa, in addition to our collaborators and directors in the UK and Netherlands. And I would like to close with this slide as a dedication to Dr. Emmanuel Nsutebu, who was the president and co-founder of the African Sepsis Alliance. Emmanuel had a huge part in the conduct of BASIS and ARCS and as well STARES. And sadly, we lost him at the end of last year, but his legacy continues. Thank you.
Thank you very much for that very illuminating presentation. You know, drawing our attention to middle-income countries, how sparse the data is, even to get information on cause of death. And of course, you know, the culture or, you know, of health-seeking behavior and health facility capacity. I think those acronyms will stay in our mind's eye when we think of stairs and arcs. But we do have some questions for you. Ahmed Tagel Katim in Sudan, and who says, does the mortality rate also focus on ICU availability at the hospital? And then I'll give you, there's a second question so that you please answer them at the same time, if you don't mind. Konsi Akot Abalo from Uganda said, can you kindly share a link to the study?
Great, thanks for those questions. The question from our colleague in Sudan asking about whether what I understand is whether we've adjusted for the availability of ICUs in any of the health facilities. That was not included in the analysis, but it's something we can explore. So thank you for considering that dimension. And then the second question from my colleague in Uganda. We'll be submitting these data for publication in the coming month. So please keep your eyes out for the link and the publication. And as I'm here in Uganda, feel free to get in touch anytime, and we can talk about this more in detail.
Great, thank you once again, Shevin. We now move on to our next speaker, who is Lisa Mellhammar. Lisa is an associate professor and a specialist in infectious diseases with a position as senior consultant at the Clinic of Infectious Diseases at Skåne University Hospital in Lund, Sweden. Her research interest includes sepsis epidemiology, long-term effects, and stratification in adults and children. Lisa has experience in using big data with clinical validation to generate reliable data on sepsis epidemiology. And I emphasize reliable. As I said earlier, data is the new gold, but it's not just any data. We need reliable data, and Lisa is just the person to talk to us about that today. Over to you, Lisa.
Thank you very much, Eleanor, and good evening or good morning, since we are worldwide. So I will talk about health record versus ICD-based assessment of the burden of sepsis and AMR, and that is antimicrobial resistance. And ICD codes, or International Classification of Disease codes, they are convenient to use because there are population-level databases. And there are two major strategies to capture sepsis using these kind of administrative data. There are the explicit sepsis codes, and that's actually the codes for sepsis. It's the recommended R codes like R65 and R572 for sepsis and septic shock. And some also uses A codes, and that codes for bacteremia, and also B codes for candidemia. But these codes have a limited sensitivity. You can also use implicit sepsis codes to capture sepsis cases. And implicit sepsis codes are combinations of codes for infection and organ dysfunction. And both these strategies have trade-offs in terms of sensitivity and specificity. Here are some pictures from a paper by Chanuri and his colleagues, and they looked at ICD codes for sepsis from 409 hospitals over a 6-year period and compared it to sepsis 3 clinical data. And they found that if you look at the coding, you see a 50% increase over time. And it may be due to economic incentives, increasing awareness and recognition of sepsis, because if you look at data from the clinical criteria, there was actually very little change. And if you look at mortality or discharge to hospice, it falls for sepsis codes, but not for sepsis 3 clinical criteria. And presumably that's because they have a different denominator. So I think this is suggesting that part of the increase in sepsis and decrease in mortality may be a shift in how infections and sepsis are coded. So what about clinical data? Well, for sepsis epidemiology, it's most often used in studies limited to certain wards, like the ICU, or to certain populations, like out of the patients with diabetes or cancer. But there are some nice exceptions, like in the Faroe Islands, they managed to cover basically the entire population in a study of sepsis epidemiology. But one big drawback is that it's very labor intensive. But I think the sepsis 3 definition is helpful because there are quite clear criteria for organ dysfunction. Yeah, I said that the sepsis 3 definition could help us because there are clear criteria for organ dysfunction. So that's good because then the result can be comparable. But it's really not like that because there is no definition or clinical criteria for infection, which makes studies a bit more difficult to compare. And that's what we want. We want comparable data so that we know what we do right or wrong in sepsis care. Now I will go through how we address these problems in a study we performed where we aimed to generate population-level data on the burden of sepsis by supplying a population-based database with information from clinical medical record review. And we used a database with all adult hospitalizations within the region of Skåne, that is the most southern part of Sweden, and we're around 1/10 of the entire Swedish population. So we're around 1 million inhabitants. 1 million adult inhabitants. And we categorized all 200,000 yearly hospitalizations into those with sepsis codes according to R, and those with sepsis codes according to A codes, and those with implicit sepsis codes. And we also had one category with infection without organ dysfunction, one with organ dysfunction without infection, and one with neither infection or organ dysfunction. And from these different coding categories, we drew a disproportionate stratified random sample for medical record review. And this disproportionateness was to increase the proportion of true sepsis cases, because we didn't want to review more non-sepsis cases than necessary. And we reviewed around 1,000 patient records, and we found sepsis in half of them. And based on these clinical record reviews, we got the sensitivity and specificity of the codes. And we're really bad at sepsis coding. The sensitivity of our codes, which we're supposed to use, was 4%. And I think we may be worse than others partly because in our hospitals we're not reimbursed for codes. So usually it's the one that the least experienced physician that registered the codes. We know the numbers of patients within each of these code categories, and we know the sensitivities and specificities. So we could therefore calculate the incidence of sepsis. And the sepsis 3 column is the clinical data, which I see as the gold standard. And according to that, 4% of the hospitalizations, or 747 hospitalizations for sepsis per 100 person years at risk. And you remember the study by Ree? They found sepsis in 6% of the hospitalizations, but they have fewer hospital beds, so the number of sepsis cases are actually in the same range. They got around 600 per 100,000. And I also have an example here, an elegant study from Germany, where 3% of the hospitalizations were sepsis, but Germany have more hospital beds, so the range is still the same, 700 per 100,000. But this study was actually very vast and thorough, and they also found that the sensitivities of the sepsis codes varies strongly between hospitals. And that is something that we haven't taken into account in our study, so that's a limitation. But these 3 studies use sepsis 3 clinical criteria, so they are comparable to some extent, but unfortunately with a bit different criteria for infection. So it's not perfect, but I think it's better than ICD codes alone. And also, clinical data allows investigation of underlying pathogens and antimicrobial resistance. And of the medical records that we reviewed, we found 25 patients with bacteria with AMR in microbiological samples, and 14 of those had an infection, and 11 of those had sepsis caused by bacteria AMR. So it's just 2% of the sepsis cases, so it's too few to do any proper statistics. But we're a low AMR prevalence setting, so it's not surprising, and our study wasn't dimensioned for AMR. But I mention it because I think it's important to try to look at the effect of AMR on sepsis, because a lot of the data we have on AMR are from clinical microbiological lab isolates, and the frequency there isn't necessarily the same as its burden in sepsis. So what I'm trying to say is that you need to validate big data. It's not enough that it's big. And hopefully we'll get machine learning models to help us to get population level data on sepsis. But these models need good data and they need validation too. And finally, I hope or plead that the sepsis 4 definition will include criteria for infection, because it would increase the validity and comparability in sepsis epidemiology. And by that, I say thank you for listening.
Thank you very much, Lisa, for your very insightful presentations and giving us the charge that we must validate big data. I do have a question from Dale Castellano from the United Kingdom, who asks, how assured are we that cases are not missed or improperly coded?
Yeah, I don't really have a good answer for that. We're not sure really. These are just estimates, but we did review of patients that didn't have any codes, so I think we should cover most of them, but yeah, I can't be sure.
Thank you, Lisa. The jury is still out on that one. Thank you.
Thank you.
So with that, I'm going to turn it over to our next speaker, who will, for the next 15 minutes, be presenting to us, and that is Flavia Machado, who is a professor of intensive care and chair of the intensive care department at the Federal University of Sao Paulo in Brazil. She has been working with the Latin America Sepsis Institute since its foundation in 2005. Flavia is also a member of the scientific committee for the Brazilian Research in Intensive Care Network, a network of young healthcare professionals involved in high-quality research in Brazil, and a member of the Latin America Intensive Care Network, comprising members from different countries in Latin America. So I welcome Flavia, please, for your presentation.
Thank you so much for inviting me to speak a little bit about sepsis in Latin America and what are our still uncovered gaps. I have no conflict of interest related to this talk. And certainly when we discuss sepsis in Latin America, we have to mention the spread in ICU study conducted by LASI in a random sample of Brazilian ICUs. In a given day, in the random sample, we showed that 30% of the ICU beds in Brazil are occupied by patients with sepsis, and the mortality rate was really high. We tried to repeat this sample, this random sample in emergency departments, and it was not possible. So we did a convenience sampling of emergency departments in Brazil, which, as we know, will towards our results to a better quality because there are hospitals that can participate in research. And you also reported a very high mortality rate even for private hospitals in Brazil because it's an emergency department, and much higher in public hospitals. But more interestingly, what we showed is that the patients who were admitted on those days with acute sepsis had a lower mortality rate related to those patients who were admitted for sepsis in prior days and were still breathing in the emergency department. And their mortality is lower than the patients that were admitted for another reasons and complicated their boarding in the emergency department with a nosocomial sepsis. We also did Infected MAPA study, trying to know about the attributable mortality for sepsis in Brazilian hospitals. And this was a multi-center study looking at the last 50 deaths in those hospitals and making a case control study. And what we found is that the attributable mortality for sepsis, it's increased along the hospital admission and can reach even 20% in medical patients, showing that it is not from their comorbidities that patients are dying. There's a very interesting data also coming from Mexico. This is the study from Luis Gordo in the emergency departments in Mexico. And they found out that the compliance rate with the bundles is quite low. And this was also associated with high mortality rates, as we found in Latin America, for instance, with 65% mortality rate in septic shock. And Elisa Stensore, her group, who have already shown previously the high mortality rate in public hospitals in Argentina, just published this very nice data in this multi-center study in Argentina ICUs, showing that 50% of the patients who were admitted in those hospitals had some sort of infection, either as admission, as a complication of their hospital stay. But interestingly, as we know, the presence of a multi-drug resistant organism was associated with a very higher risk of death. And of course, there is also cost related to this MDR issue, as we could see on this very nice systematic review about the increased costs related not only to premature deaths, but also the increased costs related to the hospitalization. And some of the countries that are here are countries from Latin America. But as we can see, this is a problem worldwide. In pediatrics, in Latin America, we had the publication of the spread in intensive care units, the pediatric intensive care units. As we can see, this was also a random sample, so it reflects what happens in our ICUs, and the mortality rate was also pretty high for pediatric patients. The most interesting thing is that this group joined with the Latin group, and they just finished the data collection for the spread in Latin and Iberia, where 21 countries collected data in a single day in more than 175 ICUs. The data is being now analyzed, and we hope we're going to present this on the next GSA Congress. Well, what are the gaps uncovered? This is a very difficult question to do. But I selected these 5 gaps that I think that we still need to do a lot about. One is the broader view, a broader view of the burden. And this is because what we are measuring right now is the burden in the hospitals, and not exactly the burden of sepsis in our countries. This is a very interesting study that talks about this. This is about lower respiratory infection in children. But what they do, they systematically reviewing found what was the incidence and mortality related to community low respiratory tract infection. And on their study, as in hospitals, they could estimate that the number of deaths, for instance, that are hospital-based, is only 19% of the whole total number of deaths. This might not be numbers, there can be a lot of critique about that, but the thing is, we are not measuring completely the burden of sepsis when you look only at our hospitals, because there are a lot of problems in our settings related of not reaching care. There are delays in the decision to seek for care. They are related to the lack of awareness or the absence of health literacy and cultural beliefs, and because people do not trust the healthcare system. And even after the decision to seek for care, there are problems in reaching this care because of accessibility and socioeconomic factors, like a family can spend their whole household income in some countries just to reach a hospital. And even after reaching this hospital, there are going to be all the problems related to what we have been discussed about diagnostic issues and resource constraints. And accessibility is not accessibility to ICU care is also very complicated in Latin America, as we know. I know that there are countries where this is worse, but even in the middle-income countries in Latin America, we can struggle to have an ICU beds, and most of the countries are lower. They have lower viability than what is recommended by the World Health Organization. And there is also the issue of transferring. This is a study that we made in our database. LASI has a body improvement program in place for the last 20 years. And we look at those patients who were only emergency department patients and who were transferred from one facility to the other. They were in the emergency department in one place and were admitted in a hospital in another place. And we compared them with the patients that were not transferred. And in this multivariate analysis, the issue of being transferred was associated with a 1.5 higher mortality rate. And this was present even in private hospitals because of the patients don't have coverage from the healthcare insurance, so they need to be transferred. And of course, in public hospitals because of bad availability. There is also a need to cover better this trajectory of the patient. And this was what I know that this is in Portuguese, but it's just to look at it. This was covered by our last sepsis, the World Sepsis Day last year in LASI, where we discussed a lot this trajectory of the patient and how we're still struggling with the patients that get out of the ICU to a general ward and are just in this vital cycle of being readmitted in the ICU. And even when we get them outside of the hospital, they are still getting back to the hospital because we are not taking care of the survival, which is another gap. And LASI has this very nice program, which is called Rehabilita Sepsis, where we discuss with multi-professionals, they discuss with survivors and their families, how can we do a better care and improve survivorship. And we know very little about this in Latin America. There are not a lot of researchers trying to determine what are the impact of sepsis and the post-discharge health. This is this nice study coming from Hedges Rosa, where they study 500 patients and look at 1 year after hospital discharge and see that the percentage of cognitive dysfunction, PTSD, and physical dependence was quite high in those patients, even after. So all the problems that the high-income countries are already facing on this rehabilitation of the septic patient, we are still very far from them. We are struggling to get our patient outside of the hospital, and we do need to do a better job on this. And we are capable of this. So another of the gaps that are uncovered is the research gap. Not only we need to understand better the epidemiology, but also need to find our own answers to research questions. Then we have this capacity. We have to remember that in Latin America, we do have the Latin American intensive care network we live in, who is now running and finished the Andromeda 2, which will find the role for capillary refill time. And we have RIPNet, the Brazilian Research Intensive Care Network, that is just beginning the NOVA trial with vasopressin, early vasopressin in shock patients. So if you are able to do this very complicated and sophisticated RCTs, I am sure we are also able to do better research on sepsis epidemiology. And also, we cannot have to mention the knowledge gap. And Latin America is also doing good things about this. There is this initiative from the Federación Panamericana e Ibérica. They are in a joint effort with the WHO OPS for Latin America. And also in Brazil, we have a free of charge learning course that has been already accessed by more than 22,000 people with more than 600,000 lectures that were already visualized. So our take-home message is that the burden of sepsis in Latin America, as we know, remains high. We do have to challenge the problem of antimicrobial resistance as other resource-poor studies. There is this critical need to improve our understanding of the burden of sepsis outside of the hospital. We need to get out of our walls and look at the whole patient's trajectory and look at our survivors. And these important questions can be answered by reducing the research gap and the increasing awareness. Thank you so much.
Thank you so very much, Flavia, for your very interesting presentation on the Latin America perspectives, talking about accessibility to ICU beds being complicated, challenges with transfers, and, letting us know that there are also research and knowledge gaps. I don't see a question specific to you. There is a question which came, I think, for Lisa on coding. So, Mr. Abdul Halim, we shall ensure that question is directed to Lisa so that we can still follow up with you and respond to your question. So, just to say a big thank you to Flavia again. So, I will now go on to our last but certainly not the least speaker, Lowell Ling, a clinical assistant professor at the Department of Anesthesia and Intensive Care, an intensivist with special interest in critical care, sepsis, and organ dysfunction. His research uses epidemiological, clinical, and genomic approaches to understand sepsis. Lowell Ling and his team have used electronic health records to estimate population-level incidence and mortality of sepsis. Lowell is the secretary of the Asian Critical Care Clinical Trials Group and a member of the Asia Pacific Sepsis Alliance. The floor is yours, Lowell Ling.
Thanks, Eleanor. It's great to speak at World Sepsis Congress. Thanks so much for asking me to speak about an update and about sepsis epidemiology and clinical data from Asia and Australasia. Here are my conflict of interest. Some of these entities have sponsored my research. I'm very grateful for their help. So for the next 10 minutes, I'd just like to give you a flavor of the sepsis incidence and mortality that we know about in our Asia Pacific region. And then lastly, to touch a little bit about the critical care data or provision of critical care, and some of the things that I might share with you might surprise you. So again, this was a landmark study from Professor Rudd and Professor Mohsen, which you've heard all about. But from my side, what I'm interested in is actually the trend that they reported in the study. They said that, in fact, if you look at the incidence globally of sepsis burden, it has decreased by 37%. And mortality has decreased by 53%. And of course, if you look at the Asia Pacific region, you can see that there's a huge range in terms of the sepsis burden, ranging from China all the way to India and then to Australia as well. But if you look closely, have we really beaten sepsis? Are we winning the battle? Or are we just picking numbers in a haystack and trying to figure out what's really going on? If you look at the local studies which have been performed compared to the GBD study, it tells a slightly different story. So if we look at the 6 different countries and regions that I've picked here, Hong Kong, China, South Korea, Taiwan, Australia, and New Zealand, there's a huge range of sepsis incidents that has been reported in the local studies. And in fact, if you look at Australia and New Zealand, for example, thought to be relatively close to each other, both in terms of the healthcare system and also the population and case mix, you can see that there's almost a 10-fold difference between the 2 different countries. And if you look at sort of across the region, we're quite similar to Taiwan in terms of Hong Kong, and we're quite similar to Australia. And so why is New Zealand so low in their sepsis incidence? And if you look at the relative change over time, it also tells a slightly different story to what was reported in the GBD study. In fact, all of the studies that were done locally have reported an increasing sepsis incidence over the last 3 to 10 years. And if you look at case fatality rate, it's also similar, in that it's very wide-ranging. Again, Australia and New Zealand reporting really, really different numbers. So almost a 4-fold difference in terms of survival between Australian patients and patients who are managed in New Zealand. How could that be? Is that really true? And similarly, if you look across our region, we do have some similarities. So between Hong Kong and Taiwan, and perhaps South Korea, we're roughly in the same ballpark, same with New Zealand as well. So which one is it? Well, if you look at the relative change for case fatality rate, again here, we're going to be reporting some really different numbers. Almost all the local studies have said that, in fact, case fatality rates are decreasing, although they're decreasing at slightly different rates. But South Korea actually reported an increase in case fatality rate. So why is that? Well, one of the reasons could be down to the difference in population, healthcare system, and intrinsic differences in the infections that are afflicting the population. But more importantly, this could all just be down to the methodology. So all of these studies have used administrative codes except for the one that we presented in Hong Kong. And as we heard from Lisa, these codes are usually discharge codings from discharge summaries, ICD-9 or ICD-10 codings. And they are also recorded in death certificates. And as you heard from Lisa, there are many, many pitfalls with administrative data. The first thing is that with changes in coding practice, and over time, we're better and better at getting to code correctly for sepsis, then naturally, because we're coding for more for sepsis, and therefore the apparent incidence would go up. And with World Sepsis Congress making a huge hit around the world and educating everyone about sepsis, sepsis awareness is increasing around the world. And because we're more aware of sepsis, we're going to code for more sepsis. And as Lisa also touched on this issue, that healthcare systems which work on an insurance-based system, they have more incentive to code for sepsis because sepsis pays for more to the healthcare system. And so all of these are really factors which affect the accuracy of using administrative data to provide estimates of sepsis burden. And this really makes it really difficult to compare within region and country over time, and also between countries and regions if we want to talk about comparative studies. So again, this has really been work that has been going on now for about 5 to 10 years. First pioneered really by Professor Chenu Rhee in the States and also the CDC. They have really opened up this space by using electronic health record, using clinical data stored there, high fidelity data that we use every day in the clinical setting, such as platelet count, bilirubin, creatinine levels. And they found that by using this compared to diagnostic coding, it provides much stable, much more objective measures of sepsis parameters, incidence and mortality rates. And we have also replicated this in Hong Kong, and we also found very similar findings to them. And so really, the hope is that with more ubiquitous use of electronic health records, we'd be able to do this more on a regional and perhaps a national level, and more places can be using objective clinical data to calculate the sepsis burden in their locality. But until we can do that, as Lisa pointed out, it's really important that we validate our sepsis coding to make sure that what we're coding is accurate. And to this end, I think more work needs to be done to show and validate whether how we're coding for sepsis is accurate. Now we're going to switch slightly to a different flavor, which is in terms of provision of critical care and sharing a little bit of clinical data from Asia-Pacific region. We often think about sepsis as a disease which is most often treated in the intensive care unit. And partly this is true. So this is a study that we did with the Asian Critical Care Trials Group, where we looked at over 380 ICUs in our region in the Mosaics-2 study. And we found that 1 in 5 patients who are admitted to our ICUs are in fact admitted for sepsis. So sepsis clearly is a huge burden within the intensive care unit. But what about patients which are outside of the ICU in the hospital setting? Well, if you look at the data for these patients, something really interesting comes out. So in New Zealand, only about 17% of their patients who have sepsis are admitted to the ICUs. Japan, same. 17% of the patients who have sepsis are admitted to ICUs. Thailand and South Korea, 15%. Thailand, 17%. And Hong Kong, 13%. So we're all roughly in the same ballpark. Roughly between 10 to 20% of our patients who have sepsis are managed in the ICU. So what happens to the other 80%? Well, first of all, why is the number so low? One of the key reasons is that in Asia Pacific region, we actually have relatively low number of critical care beds compared to high-income Western countries. So we're ranging from around 1.5 in Pakistan, and then the upper limit is roughly around South Korea, where there's about 10.6 critical care beds per 100,000. And in this space, Taiwan is a slight anomaly. Australia and New Zealand are roughly in the same area in the ballpark, but USA is much further ahead. They have around 34 critical care beds per 100,000. So naturally, the threshold for admission to the ICU would be much different, and therefore a lot of our patients are in fact managed on the wards rather than the ICU. Well, you might turn around and say, well, Lowell, maybe the patients who are not admitted to the ICU are not very sick. Well, let's see. So we traditionally think about patients who need organ support for sepsis, such as mechanical ventilation, need for vasopressor therapy for septic shock, and dialysis. These patients, I think no one would argue that probably in a high-income setting where resources should not be a problem, ought to be managed in an ICU. But in fact, they're not. So this is data from the Asia Pacific region. I can share with you that 53% to 57% of patients who are on mechanical ventilation who have sepsis are actually managed in the general ward. Let me repeat that. 53% to 57% of patients who are on mechanical ventilation who have sepsis are managed in the general ward. And the number for vasopressor is the same, or in fact, even much higher. So 37% to 73% of patients who are on vasopressors for septic shock are managed on the general wards. Same for dialysis, roughly around half. Okay, so you might say, okay, well, maybe this is data coming from low-income settings, right? Because this is resource limited. But in fact, this is coming from Thailand and also Japan and Hong Kong, which are high-income settings. Okay, so what we're showing here is that, in fact, our traditional thinking of sepsis being a disease which is exclusively treated in the ICU and critically ill patients with sepsis are in the ICU is wrong. And in fact, this stretches all the way from low-income setting all the way to high-income setting whenever critical beds are limited. And so we're really touching at the tip of the iceberg when we're studying, sepsis management, processes of care, outcomes. And if we're limiting ourselves to studying in the ICU, we're really not touching the bulk of the disease, which is managed in the wards. And as you heard from Prof. Flavia, in fact, a lot of patients in low-income settings perhaps are not even hospitalized. So we're really not even scraping the true epidemiology and also understanding how we're caring for these patients if we're just studying the patients in the ICU. So just a quick snapshot of the Asia Pacific region. I've shared with you about the sepsis burden, which is quite variable across our region. And we really need to improve our capacity and accuracy in terms of actually capturing sepsis burden by surveillance methods in our region to better understand what we're facing. And there's really a need to understand that actually, in fact, provisions for critical care for sepsis is commonly provided in the ward setting, even in high-income settings. And that's an area that's often neglected. We really need to focus on the management and outcomes of patients in wards because that's actually the bulk of where the sepsis occurs. And of course, as Prof. Flavia says, outside the hospital as well. So with that, thank you very much for your time and hope you enjoy the rest of the Congress.
Well, thank you, Lowell. Another illuminating presentation. And, thank you for building on, Mohsen and Lisa's presentations around, improved coding and the importance of electronic health records. And then the surprising and revealing information as to how, mechanical ventilation happens in general wards, even in high income settings. That is truly revealing. Those of you who would like to stay on with your questions, we do have one from Tatiana Siomartan from Romania, who says, what is the nurse to patient ratio in general wards in your area? Oh, that's important, Lowell, especially as you revealed to us how mechanical ventilation happens in the general wards. So can you answer that question, please, from Tatiana?
Yeah, thank you. So our data is, we're just hoping to publish that very soon. We have not revealed the nursing ratio per se, but in general wards in Hong Kong would have roughly around 1 at nighttime. Maybe I'll just say when it's at its worst, could be down to about 3 for 50. So, and it's quite really stressful for the nursing staff to look after these patients, but we really have no choice.
Wow, stressful indeed, which is why we also need to look at, self-care amongst, healthcare professionals. So thank you again. It's really left for me to thank our erudite speakers, every single one of you bringing the different perspectives. Thank you, and thank you again. Of course, we thank our esteemed audience. I encourage you to visit our website, sign the World Sepsis Declaration. Yes, make that commitment and sign the declaration. And follow us on Facebook, on Twitter. We're on Instagram, LinkedIn, and TikTok. We must not fail to thank our generous sponsors. We would like to really thank our generous sponsors. And once again, thank all our speakers and thank our esteemed audience. Remember to follow us on socials, and there you have all our sponsors. All the very best.